Greetings. Let us learn about the mechanisms underlying heartburn. Uh, these are my acknowledgements. Please read this slide. When a patient presents with heartburn, they typically complain of burning sensation in the retrosternal area, typically after eating food or bending forwards. And before you think heartburn is related to acid reflux, think about the structures in the heart. And in anyone complaining of heartburn above the age of 40 or 50 with other cardiovascular risk factors, make sure it is not coming from the heart. You should not mistake heartburn as always due to acid reflux. So, important to consider and rule out ischemic heart disease in anyone with other comorbid conditions. In some, you may not even know, but think about heart. So, let us look at the mechanisms. Heartburn is related to acid refluxing up into the esophagus. And typically, we all do have some amount of acid reflux into the esophagus because of transient lower esophageal sphincter relaxation. And the saliva neutralizes the acid that is coming down the esophagus, and the peristalsis of the esophagus pushes it down into the stomach. When there is excess amount of acid reflux into the esophagus, the acid does cause some amount of injury and inflammation, and subsequently cause irritation of the neural pathways. At this juncture, keep in mind that you may have irritation of the nerves either with injury and inflammation of the esophageal mucosa, in which case you call it gastroesophageal reflux disease with inflammation that may manifest as erosive esophagitis. In some cases, you may not see the inflammation. It could be microscopic or physiological change in the cells and cause irritation of the nerves, and that irritation and sensitivity leads to perception in the brain, and that perception is felt as heartburn. Whenever you see any patient with GI complaints, think about the brain-gut axis relationship. That is, are the nerves getting irritated? And what is the setting of the sensitivity of the nerves? Where is the threshold for firing of the neurons? And how is the brain perceiving? And this concept is really important to keep in mind, because some may have sensitive neurons and some may have a very perceptive brain. And that can manifest as with other symptoms like anxiety, neurosis, etc. And that may lead to people presenting with various GI symptoms. So any GI complaint, think about the brain-gut axis relationship. So coming back to the heartburn, this could be related to acid reflux, sensitizing the neurons, and the brain perceiving it. So let us go back and look at it from the mechanisms put together here. So we have talked about acid reflux, irritation, inflammation of the mucosa, and firing of the neurons, and the neural impulses going up and being perceived as heartburn. So there could be three different components when you think about heartburn. Is there abnormal acid reflux? Is there a hypersensitive esophagus? Or is there hypervigilance? Think about these three concepts: hyperacidity, hypersensitivity, and hypervigilance. Coming back, keep in mind the brain-gut axis relationship. So let us look at the different components, different mechanisms for heartburn. Let us look at the acid exposure time, and when there is there increased acid exposure to the esophagus, and when there is acid exposure, does the patient perceive that exposure event with symptoms of heartburn? Then is there damage to the mucosa, and is the patient perceiving it as heartburn? And then putting all these two things together, we come up with a diagnosis. So let us look at it. So if you have somebody with increased acid exposure time, that is measured by a pH recorder, and the patient perceives every acid reflux or majority of the reflux episodes as heartburn, and there is also on endoscopy damage with erosions in the esophagus, and that heartburn with damage, increased acid exposure time, and a positive symptom trigger is diagnosed as gastroesophageal reflux disease. So we've learned about gastroesophageal reflux disease. There is damage in the form of erosions, and there is increased exposure time and symptom trigger. Let us look at another format of the same problem, but with a little bit of difference. Here, you also have increased acid exposure time and a positive symptom trigger, but when you do endoscopy, on visualization, you do not see any erosions, or maybe LA grade A, because LA grade A can be seen even in so-called normals. So when you don't have damage, but the patient is perceiving heartburn and there is increased exposure time and symptom trigger, positive symptom trigger, then you diagnose it as non-erosive reflux disease or NERD. So in both GERD and NERD, there is increased exposure time, acid exposure time measured by the pH, and whenever there is an acid reflux, the patient is identifying it with a positive correlation to heartburn, positive symptom trigger. With damage is GERD, without esophageal damage is NERD. Now let us look at something else. Here, acid exposure time is below 4%. All right. But in that, whenever there is some amount of acid reflux, the patient recognizes it as heartburn. There is a positive symptom trigger. Endoscopy is negative, and that heartburn is diagnosed as reflux hypersensitivity. So in reflux hypersensitivity, you have a normal esophagus, on endoscopy, normal pH recording, and whenever there is some amount of so-called physiological reflux episode, the patient recognizes it as heartburn. Here the mechanism is hypersensitive esophagus. All right. So we talked about GERD, we talked about NERD, and we talked about reflux hypersensitivity. Now let us look at the next type. Here, acid exposure time is not increased, and whenever there's some amount of so-called physiological acid reflux, the patient does not identify that as heartburn. Endoscopy is negative for damage, but the patient complains of heartburn all the time. And that is because of hypervigilance or functional heartburn. So I hope this is helpful to you. And when you're looking at a patient with heartburn that's been going on for some time, do an endoscopy. If the endoscopy shows obvious damage, either with erosions or Barrett's esophagus, you know that this is GERD. If the endoscopy shows no damage, then before you label it as NERD, reflux hypersensitivity, or functional heartburn, you do pH recording of the esophagus. If the pH recording shows increased acid exposure time and positive symptom correlation with no endoscopic damage, you diagnose it as non-erosive reflux disease. On the other hand, if the acid exposure time is normal, but whenever there was some amount of acid reflux, there is a positive symptom correlation, then you call it as reflux hypersensitivity. On the other hand, you have no increased acid exposure time and no symptom correlation, but the patient complains of heartburn, then you call that as functional heartburn. In any patient, especially in the late 40s, 50s, 60s, think about and rule out ischemic heart disease when you're stuck. That's a very important thing to consider, and hope this is helpful. Thank you.